holds the key to the gates of the healthcare system. But we share this with the other colleagues in the field, not just us. And this is not only a privilege, but a huge, very huge responsibility, since we are already in the midst of the implementation of universal healthcare. Being here to learn the latest developments and updates in the management of hypertension, type 2 diabetes, and other cardiorenal complications will surely be a gainful experience for family physicians like us as we advance holistic care for Filipino families. Again, in behalf of the Philippine Academy of Family Physicians President, Dr. Karin Garcia, and the rest of the Board of Trustees, we thank you, our partner, and let's all have a very meaningful, engaging, and fruitful discussion this evening. Again, good evening to everyone.
Thank you, Dr. Ana Guia Limpoco. Our session chair for this evening is Dr. Bien Matawaran. Dr. Matawaran is chairman of the Department of Biochemistry, Molecular Biology, and Nutrition at the University of Santo Tomas Medicine and Surgery, and chief of the section of Endocrinology, Diabetes, and Metabolism at the UST Hospital, Manila, Philippines. To welcome you and give an overview of tonight's program is Dr. Bien Matawaran.
Hey, good evening, everyone. Magandang gabi po. So good evening, everyone, to our friends here in Marriott, as well as our friends who are joining us virtually from around the region. So magandang gabi po sa inyong lahat. So we're here in the Cardiometabolic Congress. So cardiometabolic or CVM diseases represent a leading cause of morbidity and mortality worldwide. And this is considered by the WHO as the epidemic of the 21st century. CVM conditions, of course, include hypertension and diabetes, which, as you know, are common risk factors for cardiovascular disease. Fortunately, various scientific studies in more recent years have allowed us to provide more holistic care to health patients living with CVM diseases through continuously advancing therapeutic options, as well as evolving guidelines designed to improve overall disease management. So for tonight, we will be treated because we have invited an esteemed panel of speakers to share their experience and expertise with us. So for tonight, we have this agenda, the CVM Congress over the years and beyond, improving patient outcomes from guidelines to practice. So we'll be hearing from Professor Thomas Unger, current guidelines in the management of hypertension, where do ARVs fit in, and hypertension and AF conundrum. We'll be hearing from Dr. Janaka, new approach to type 2 diabetes management. Do DPP-4 inhibitors like linagliptin still fit in? And he'll talk about prevention of cardiorenal complications in type 2 diabetes. We'll have a panel discussion and a question and answer portion after those two important talks, and we'll be inviting as well our nephrologist, my teacher, Dr. Oscar Naidas, as part of the panel. And of course, we'll be hearing from our partners from the Philippine Academy of Family Physicians, Dr. Limuel Anthony Abrogena. Okay, so to start our session for tonight, let me introduce a patient case. Okay, so I was tasked to talk about one illustrative case of hypertension and diabetes. So these are my disclosures, and we are presented with Carol, a 65-year-old housewife who was lost to follow-up. After missing a year of consult, she claims to be compliant with her medications. She's a known diabetic and hypertensive with current blood pressure of 145/90, BMI of 23 kilograms per meter squared, with non-proliferative diabetic retinopathy. Her laboratory results prior to this consult, so prior to missing her consult, was an FBS of 110 milligrams per deciliter and an HbA1c of 6.7% with an EGFR of 51 mils per minute. So in this current consult, she came in with this recent blood test, which showed an elevated FBS of 147 milligrams per deciliter, now with elevated HbA1c of 7.7% and a low EGFR of 31 mils per minute and urinary albumin creatinine ratio of 598 milligrams per gram. She's currently, no, prior to this consult, or she continued her medications on a sulfonylurea, glimepiride at 3 milligrams once a day, metformin at 2 grams daily, with losartan at 100 milligrams daily, amlodipine at 5 milligrams, atorvastatin at 20, and aspirin at 80 milligrams. So in this patient, upon seeing her in this current follow-up, it is very important that we do address several parameters that will eventually reduce diabetes complications. And in the American Diabetes Association standards of care, it is very important that for this case as well, that we do address hyperglycemia. In the ADA-ESD combined recommendation in this holistic person-centered approach to type 2 diabetes management, when we do think of medications for hyperglycemia, we have to think of medications that are highly efficacious in lowering HbA1c, as well as we have to consider the avoidance of hypoglycemia in patients that are high risk, especially our patient who is 65 years old, as well as with CKD already. And with that being said, it is very important and that in choosing glucose-lowering agents in patients with type 2 diabetes and CKD, that we look at the current medications of Carol. Remember, she has with her a sulfonylurea and metformin. Though they are highly efficacious agents in lowering HbA1c, we have to remember as well the safety profile. For in sulfonylurea, we all know that there is increased risk for hypoglycemia, again, especially in high-risk patients who are elderly, as well as those with renal insufficiency. And when choosing those anti-diabetic agents, we of course have to think of other agents that may be as efficacious, but may be better with regards to safety, especially on hypoglycemia risk. With that being said, we are well aware of two very important CV outcome trials for a DPP-4 inhibitor, and this is linagliptin. We've learned from both the Carolina and the Carmelina trial that linagliptin provided evidence across a broad spectrum of type 2 diabetes duration, cardiovascular, and renal risk, especially in the Carolina, wherein patients were randomized to glimepiride and linagliptin. And this study showed the occurrence of any hypoglycemic adverse event was significantly lower with those patients given linagliptin versus that of glimepiride. And if you look at the composite endpoints, key secondary sustainability endpoints, we see that more patients were able to reach an HbA1c target of less than 7% without need for rescue medication, without weight gain of more than 2%, and without moderate to severe hypoglycemic episodes compared to those patients given glimepiride. And this is why it is also important that if we do compare linagliptin to other DPP-4 inhibitor, it is quite simple to use, mainly because we do not need to adjust the dose depending on the GFR of the patient. So if you look at different evidence of different DPP-4 inhibitor, we now have a DPP-4 inhibitor like linagliptin that is proven to be safe in patients with multiple risk factors and even for those with established cardiovascular disease, and some data with regards to renal protection. So going back to our patient who is already on metformin, in the KDIGO guidelines for patients with type 2 diabetes and CKD, that we have to remember that if you have patients with EGFR of less than 45, that you have to reduce the dose of metformin or even discontinue for those with EGFR of less than 30 mils per minute. But aside from that, we can also give agents that may be cardiorenally protective, and that would include your SGLT2 inhibitor. So in the recent ADA-ESD guidelines, it says that SGLT2 inhibitor with primary evidence of reducing CKD progression should be given in those patients with CKD, and the use of SGLT2 inhibitors in people with an EGFR of more than 20 mils per minute is highly recommended. Once initiated, should be continued until initiation of dialysis or transplantation. We saw in the EMPA-REG trial the benefit of empagliflozin versus that of placebo with regards to reduction in the 3-point MACE. But more than that, we also saw significantly reduced relative risk of incident or worsening nephropathy favoring empagliflozin versus placebo in the EMPA-REG trial. In addition to it significantly producing a slow decline in the eGFR versus that of placebo. But more applicable to our patient who already has CKD, we have in the EMPA kidney trial, the benefit of empagliflozin at 10 milligrams, even for those patients with eGFR of between 20 to 45, as well as those patients with eGFR of between 45 to 90, and urine albumin to creatinine ratio of more than 200 milligrams per gram. And this is also the combination of these two agents would address 5 out of the 8 core defects of hyperglycemia in patients with diabetes. So that's hyperglycemia. But aside from that, we also have to, of course, target BP lowering or blood pressure. And in the KDIGO guidelines as well, it is very important that we start our patients with diabetes and CKD RAS inhibitors at maximum tolerated dose. This is very important because several studies have shown that only about a third of patients are given the maximum doses of RAS inhibition. And this is true even for those patients with CKD and diabetes mellitus. In the 2022 and 23 ADA guidelines, they highlighted that in patients with CKD who have more than 300 milligrams per gram urinary albumin, a reduction of 30% of greater in milligrams of urinary albumin is recommended to slow chronic kidney disease progression. That is why it is very important to control blood pressure and maximize doses of our ARBs and ACE inhibitors, reaching a target of less than 130 millimeters mercury for most of these patients. And we can achieve that when we use medications, especially antihypertensive agents with long plasma half-life like telmisartan, because it has been shown that compared to other ARBs like valsartan and losartan, the long half-life of telmisartan translated to superior BP reductions compared to these other ARBs. And in the on-target trial, for those patients with diabetes with target organ damage, it has shown that it is beneficial in targeting this group of patients. So when I go back to our patient Carol, we revised some of her medications, now using a DPP-4 inhibitor together with an SGLT2 inhibitor and choosing another ARB for blood pressure control and increasing our statin for cardiorenal protection. Okay? So that is our takeoff case for this morning. And let me introduce our speaker to really talk about in detail management of hypertension as well as management of diabetes. So to start our first session on current guidelines in the management of hypertension, let me please welcome Professor Thomas Unger.
Thank you, Dr. Bien Matawaran. We encourage tonight's attendees to actively participate in tonight's discussion. Please feel free to send in your questions at any time throughout the program, which will be addressed during the open forum. If you are joining us online, you may send in your questions using the Zoom Q&A button at the bottom of your screen. If you are at the venue, please send your questions by using the Q&A tab on slido.com. In your browser, go to Slido and simply type the event code BICVM and then proceed to the Q&A tab. It is now our privilege to introduce to you our first distinguished speaker, Professor Thomas Unger. Professor Unger is Emeritus Professor of Pharmacology and Experimental Medicine at Carrier School for Cardiovascular Diseases at Maastricht University in the Netherlands. Tonight, he will provide updates on current guidelines in the management of hypertension, followed by a discussion on hypertension and atrial fibrillation. Let us all welcome Professor Thomas Unger.
Well, ladies and gentlemen, good evening. It's a pleasure to be here. You know, when you come to a country like the Philippines from Europe, there are always two questions that you are asked. The first is, how was your flight? My flight was totally uneventful. I couldn't say anything about that. And the second is, the second is, you must be tired. And the third is it the first time you are on the Philippines? So I checked my passport and I found out it's the fourth time that I'm in Manila. So it's not the first time anymore, but thank you very much for the invitation. Right, today, as already announced, I will introduce you to something absolutely new, and this is hypertension management. You will say, well, we have heard so much about that over the years, but there are still some facets which you may not familiar with. So let's talk a little bit on guidelines and the management of hypertension, and of course, where do the ARBs or the SARTANs come in? And we start in the 13th century in Padua, in Italy. And you see they had a university there already. And there is the professor teaching. And we have all the students there. And we have also the young doctors or older doctors, as you can see. And now they discuss things. My dear friends, what shall we discuss today? Hypertension, of course, there's one. The other, well, this guy is always sleeping away. You can see that. And he says, oh, the silent killer. I've heard so much about that. Hypertension is a global burden. We have heard about that also here in the Philippines. And we need to know more about recent guidelines and about the best drugs for treatment of hypertension. Well, what is the situation? Hypertension is really a global burden. I don't say anything new to you. This is a paper a couple of years ago in Circulation. In 2010, there were about 1.4 billion hypertensive people in the world. And interestingly, in the high income countries, it's only about 350 million, but in the low and middle income countries, it's more than 1 billion. So this is where the music plays, not so much in the high income countries. And if we go to the Philippines, we have already heard 38% prevalence of hypertension, which is coming close to what in other countries we also see. Although when you look at this map, you can see that the Philippines in 2010 were still relatively low with the average blood pressure compared, for instance, to some African countries. You also know certainly that the risk doubles, which each 20/10 millimeter increment in systolic and diastolic blood pressure. And when you have a blood pressure of 175/105, you have an 8-fold risk. And don't forget, this risk doesn't come alone. It comes together in many patients with diabetes, with coronary artery disease, with other factors, with lipid disorders. And when you take all that into account, you have a tremendous increase in the cardiovascular metabolic risk in these patients. Right, guidelines. I just do it very quickly on the guidelines and compare a little bit what we have. You know that the Americans, the US Americans, always give their guidelines to the rest of the world. The Europeans do it. And also the International Society of Hypertension did it 3 years ago. And I had the privilege to be the first author of this publication in hypertension. Right, and I really confine myself to drug treatment of hypertension. And there is something very special and unique about these guidelines of the ISH published in hypertension. And this is that we took care not only of the industrialized world, like what you see in most other guidelines, but we care also of low and middle income regions in the world or settings in the world, wherever they are. Because in many settings in Africa, in Asia, but also in rich countries, they don't have access to drugs, they don't have access to all the facilities, equipment, and so on, and to doctors and hospitals. But then they have to deal with hypertension as well. So we tried to divide our guidelines throughout, if possible, into essential and optimal. Let's start with optimal. This is when you're close to a university hospital or whatever, maximal possibilities, and everything is there. Drugs are there, doctors are there, nurses, and also all the equipment. So what can we say about drug treatment? We start as step one in, let's say, uncomplicated hypertension, if that occurs, with a double dose, with a combination of a RAS, this is a RAS inhibitor, and a calcium antagonist. This is different from the prevailing guidelines in the US and in Europe, because they also give you a chance to start also with a diuretic, but I'll come back to this. Step two, we increase the dose to a maximal tolerated dose. That's step two. If that doesn't work to control hypertension, then we introduce step three, and now the diuretic comes in, possibly a thiazide-like diuretic, but if this is not at hand, you can also use the thiazide. Then step four, in resistant hypertension, we add spironolactone, or if this is not tolerated, any other drug that you can think of. So A is always a RAS inhibitor, and this is always there from the very beginning. Exemptions, if patients have mild hypertension and absolutely no additional risk factors, which is very rare, then you can start with monotherapy. Also, if patients are very old and frail, you can also do that, because you don't want to have a precipitous decrease in blood pressure. Now, also exception in patients of African descent. There you can also start with a combination of a diuretic and a calcium antagonist, because that has been shown to be as good as starting with an inhibitor of the renin-angiotensin system, because these patients depend less on the renin-angiotensin system than, for instance, white populations or Asian populations. Now, also, if there are patients with incipient heart failure or post-stroke, then you can also start with a diuretic, of course, because heart failure and diuretics go together. Yeah, this is under optimal conditions. If these conditions are not given, we go to the left-hand side. What is essential? Essential is lower blood pressure with whatever you have. It can be a diuretic, it can be whatever is available, and try to lower blood pressure by more than 20 millimeters of mercury systolic, if you can do that. And optimally, of course, below 140/90. So that is quite a difference to the optimal conditions. And you may ask, where is the beta blocker coming in? Because the beta blocker was always there. And in my country, I come from Germany, but I worked in the Netherlands. Actually, the doctors always start with a beta blocker. You can tell them what you want in guidelines. They start with a beta blocker. But in the guidelines worldwide, globally now, we reserve the beta blocker to patients with a cardiac problem, or if they want to have a baby, if they're pregnant. Then the beta blocker, of course, is there. And cardiac problems can be tachycardia, post-infarct, coronary heart disease, or heart failure, but not in the first line in the so-called uncomplicated hypertensive patients. So just to summarize this a little bit, in established hypertension, uncontrolled by lifestyle measures, of course, they have to start. We do the drug treatment threshold below 140/90. Well, if there is really a low risk, then we can also say, well, 60/100, but it's not really what I would like to see. And then optimal, if they are below 65 years, we try to give even lower, and we have heard this already, lower to 130/80, because there seems to be a benefit after the SPRINT study. And if they are above 65 years, then again 140/90. And essential, nothing available, reduce blood pressure by at least 20/10. So what do the European guidelines say to this? Basically, these guidelines, what the Europeans have published, are from 2018. They are now preparing new guidelines, which they will release in June this year. I have seen the new guidelines as an external reviewer. There is nothing really new in these guidelines. So what did the Europeans say? And they very close to the ISH guidelines, but the difference is here, you can see already, a diuretic is still in the first line. Otherwise, very similar, also applicable to diabetic heart patients and so on. So there isn't much of a difference, only that they don't have the second step, which means that you increase the dose to maximal tolerability. They don't have that. Otherwise, very similar. Different from the US American guidelines, ACC/AHA guidelines, which were published in 2017. Because the major difference is really here. As you can see, we and all the others still say hypertension is starting from 140/90. The US American guidelines now say it starts lower. It starts as 130/80. And this is based only on one study, and this is the SPRINT study, nothing else. And overnight, almost half of the adult US American population became hypertensive. Yeah, and how to treat them? You have to treat half of the adult population. This is really a challenge, I would say. But let's see what happens in a couple of years when we all get used to that. So that is the major difference between the US American guidelines and the rest of the world. And I'm really interested to see how they proceed with their new guidelines when they come out. Also, of course, the US Americans were always very proud of diuretics. So they always put diuretics in the first line, even knowing that high doses of diuretics can reduce the tolerance to diabetes. And even knowing that it's always diuretics in the first place, otherwise similar to what we have already heard. Now, so what are the differences? I think the major difference is here with the arrow. Blood pressure definitions of normal blood pressure and stages of hypertension are different. We have to acknowledge that. The world is split now in US and non-US. Inclusion of high normal blood pressure category is also not there. The blood pressure value thresholds for treatment are therefore different because stage 1 is already in US above 130 and you have to treat them somehow. And of course, these guidelines also, like all the others, don't have a differentiation of essential and optimal, what we tried in the global ISH guidelines. Well, coming back to the RAS inhibitors, first line everywhere. RAS inhibitors. Let's talk about this system a little bit. Well, it's old stuff anyway, because that's one of the oldest physiological, biological systems that we all have and share with all creatures in the world, starting from, I don't know what kind of animals, fish, and whatever that we can imagine. They all have a renin-angiotensin system. So it's a physiological hormonal system, and there are incidents where we need it. For instance, if we walk through the desert and for 8 days and we have nothing to drink, we are really happy to have a renin-angiotensin system which preserves water and salt. But sometimes it's inadequately regulated, and in many hypertensive patients this is the case. So even if you have normal angiotensin levels, this is too high for the given situation in blood pressure. So we have to do something about that. So in such case, we need to inhibit the renin-angiotensin system. Right. And of course, there is a lot of evidence that angiotensin through the AT1 receptor is also doing a lot of harm if inadequately regulated. I always have to say that. So you can see that. I don't have to go into details here. But in every organ, the heart, the kidney, the brain, the vessels, that is a problem with angiotensin via the AT1 receptor. So we try to block it as much as we can. And of course, we have two systems that can do that, the ARBs and the ACE inhibitors. Well, both classes, ARBs and ACE inhibitors, they have actions beyond blood pressure reduction. So not only blood pressure goes down, but also they are anti-inflammatory in atherosclerosis, post-MI, post-stroke. They're anti-diabetogenic, anti-proteinuric, delay the progression of renal failure, reduce or prevent left ventricular hypertrophy of the heart, and reduce stroke. All that has been proven in many, many studies in the literature. And of course, on the side of the ACE inhibitors, we have a lot of studies, especially in cardiovascular risk patients, that show the benefits of the ACE inhibitors. No doubt about that. So they can be used in the first line in the framework of the RAS inhibition. Especially the HOPE study was interesting, and I'll come back to the HOPE study a little bit later. But ACE inhibitors have a problem. I was involved in the development of ACE inhibition from the very beginning, from captopril to ramipril and so on. And what we did one day in the lab was a study that I've never published. We measured angiotensin II in the blood of rats, of spontaneously hypertensive rats, which were treated for 12 weeks with different ACE inhibitors. And we measured angiotensin II levels after 2 hours of dosage, and then after 24 hours. And it's easy for you to see that on the left-hand side, after 2 hours, we had a significant decrease of angiotensin. That's what we wanted in all groups. But after 24 hours, there was no significant decrease anymore. So angiotensin levels come back after a day or so. This is not going on for 24 hours when you treat for the next time. And interestingly, in studies here in heart failure patients with an EF of 24, when ACE inhibitors are given, in this case captopril or enalapril, when patients do have angiotensin levels above 16 picogram, which is relatively high, then the survival probability goes down. And this is the problem with ACE, one of the problems with ACE inhibition. It's never constantly there. The next thing that you probably know quite well is cough as a side effect. And this is especially true for East Asian ethnicity and East Asian populations. Actually, in Japan, ramipril, for instance, didn't make it to the market for that reason, because the Japanese said, well, we don't want that, it's too much cough. And of course, then you have the angioedema, which is admittedly quite rare, but when you have it and when it hits the wrong place in the body, like the throat, then it's life-threatening. So there is something about the ACE inhibition, and this belongs mainly to tolerability. So drug withdrawal, for instance, favors ARBs versus ACE inhibitors if you have head-to-head studies, and also favors the ARBs when you do active treatment against placebo. Yeah, that's what it is. ACE inhibitors are good drugs, no doubt about that, but they have a little problem here and there. So I would say that when we compare the sartans with the ACE inhibitors, in my mind, the better is the enemy of the good. I don't say that ACE inhibitors are bad, but the better is the enemy always of the good. And so my former boss at the Pharmacology Institute in Heidelberg, actually Franz Groß, he was instrumental in the first antihypertensives that you see on the left-hand side of this curve. And he died, unfortunately, relatively early, when the ACE inhibitors had just come to the market, but before the 81. So I actually followed up a little bit with the 8 inhibitors. And I think when you approach the ideal drug class, and ideal means the balance between efficiency and tolerability, then the 81s have a little advantage over all the others. We don't know what the ARNIs, what the SGL2 inhibitors and angiotensinogen inhibitors on a genetic level or what they do, but we will see in the future. Well, how about OnTarget and Transcend? Well, this goes actually back to the HOPE study. HOPE study used patients that had a high overall cardiovascular risk. Not all of them were hypertensives, maybe half of them, but some of them had diabetes, some were post-stroke, some of them post-MI, and so on. And OnTarget was, and HOPE was really a successful study, no doubt about that, for ramipril. Now, when we tried to devise a new study with telmisartan, we thought, well, it would be nice to compare ramipril, the golden standard of ACE inhibition after HOPE study, with telmisartan directly in a head-to-head comparison in the same population of patients. And that's what we did with the OnTarget Transcend study. So as in the HOPE study, it's the high cardiovascular risk group of patients. Going back to the HOPE study, great results, no doubt. And this is the combined cardiovascular endpoint and all the parts of it, cardiovascular mortality, myocardial infarction, and stroke. Very successful, which made ramipril one of the best-selling ACE inhibitors in the world. So how about the on-target? Well, it was devised as a non-inferiority device. That means it should be significant outcome if telmisartan is non-inferior to ramipril in the same population to protect them. The doses were 80 milligram versus 10 milligram. I think this is a fair comparison. And you see the curves were identical. So the primary endpoint was reached, non-significant difference between the two. But there was a difference here. And the difference was, again, the tolerability. There was significantly more withdrawal in the ramipril group than in the telmisartan group. And when you looked at the Asian populations, again, you see that there were almost double withdrawals than in the telmisartan group, in the ramipril group. So, yeah, it's again the tolerability. But then there was something else, and this is frequently neglected. A paper which came out by my friend Hans Mann for the kidney and for the urine, for the proteinuria, which increased over the 5 years of on-target Transcend in all patients. But you see the increase was higher, significantly more than with ramipril than with telmisartan. So again, the kidney was better protected in the telmisartan group, and this is frequently not shown. And another picture which is not shown from our studies with on-target Transcend, this is now from Transcend, a study which was made in parallel to on-target in those patients who were intolerant of ACE inhibitors and therefore could be tested against placebo, not with ramipril, but against placebo. And you see that in the hypertensive subgroup, which was the vast majority of these patients, we had a significant reduction of myocardial infarction with telmisartan against placebo. I think that was an important finding also from this study. Right then, so telmisartan was equal to the world's golden ACE inhibitor standard ramipril in reducing cardiovascular risk, but better tolerated and advantageous in maintaining renal function and heart protection. And he says, yes, this is true, absolutely. In this respect, telmisartan is quite special. So finally, what is then special about telmisartan? We have already heard with a patient case presentation that telmisartan is longer acting and so on, but why is this the case? And this is the case because of this. Telmisartan has a chemical moiety which goes directly into a pouch, which is shown by the arrow, which the other sartans don't do. They only bind to another pouch, which telmisartan does as well, but not to the second one. And this means that telmisartan has the propensity to bind more tightly to the receptor, doesn't allow angiotensin II to bind to it for a longer time. And this entails all those things that have been said. For instance, longer duration of action, longer half-life in the plasma, penetration into tissues also because it's more lipophilic. So it has some structural advantages over the other sartans, and this may explain a lot of things. For instance, also what you have already seen, comparison with valsartan over 48 hours, and you see that with telmisartan you stay low, valsartan 160 milligram goes up again. And the same true for losartan comparison with telmisartan. Of course, one has also always to be fair in these comparisons. If you use a low dose of losartan and a high dose of telmisartan, you can envisage that telmisartan is better than the comparator. So you really have to be fair. But I think telmi 40 to 80 versus losartan 50 to 100 is a fair comparison. And the systolic blood pressure was more lowered with telmisartan in direct comparison. And the direct comparison also with proteinuria, as you can see, more reduction with telmi than with losartan in the Amadeo study. And this picture you have already seen. Where does it come from? It actually comes from the on-target Transcend study in patients with high cardiovascular risk. And based on this big study, on this big trial, all those indications that you see here in red came to telmisartan, but they were not tested in the others. The others might have given the same results, but they were just not tested. So, and also after the on-target transcend study, the Micardis, in this case, 80 milligram, was given new indications by the EMEA, which is now EMA in Amsterdam, it was in London before Brexit, and the FDA in the United States. And they, as you see for the EMEA, reduction of cardiovascular morbidity in patients with a manifest atherothrombotic cardiovascular disease, history of coronary heart disease, stroke or peripheral arterial disease, or type 2 diabetes mellitus with documented target organ damage. The American recommendations are a little bit more conservative because they say only if an ACE inhibitor is not tolerant, because that was in the Transcend study, but basically they say the same. And this is why this new indication for cardiovascular risk prevention came into the play. So, well, the better is always the enemy of the good. I don't say that the others are not good. And I've been involved in all kinds of advisory boards and whatever, but telmisartan, in my view, is somewhat better. Let's come to the end. So what have we learned so far? We have learned hypertension is a global health challenge. Hypertension control is still insufficient in most countries in the world, if not all. RAS inhibition confers blood pressure reduction and tissue protection. Think of the kidney, think of anti-diabetic actions. New guidelines tell us to begin treatment with a single pill combination, SPC, always including a RAS blocker. That is standard. ARBs are better tolerated than ACE inhibitors, no doubt about that. And compared to other sartans, telmisartan has a superior pharmacological profile, which comes from this structural component. It prevents the morning rise of blood pressure, which is so dangerous, and protects the kidney and the heart. Well done, my friends. You have listened attentively, and I hope you have done the same, and I thank you for your attention. So, you have to endure me another time. I'm sorry about that. I wasn't really aware that I had to do this talk, but I was given this challenge, very short notice, I must say. Now, atrial fibrillation is a very, very challenging topic and a complicated stuff. And I try to guide you a little bit through that, but relating mainly, if not exclusively, on the relationship between atrial fibrillation and hypertension. I'm not going into other fields. This is something for the rhythmologist in cardiology, and I'm not a rhythmologist in cardiology. Right, so now we are not in Padua, we are in Paris, in Europe, at the Sorbonne, which was also funded in the 13th century. Old university, and you see the professor, again, the students on the left on the floor, where they should sit, and then the doctors, not yet professors, but want to be professors, on the right-hand side. So they are in discussions. And mind you, in this case, now they don't talk about hypertension, they talk about atrial fibrillation. So AFib is a serious condition which can lead to heart failure and stroke, and also to death. In 2010, 10 million people had atrial fibrillation in Europe alone, so quite a number. AFib goes along with hypertension? That's the question. Now let's see what we have in the literature. Atrial fibrillation is the most common sustained arrhythmia encountered in clinical practice. It is associated with a significant increase in thromboembolic complications, for example, stroke and thromboembolism. Loss of synchrony between atria and ventricles leads to continuous atrial and ventricular mechanical dysfunction, followed by the development of heart failure and decreased functional capacity. Patients with AF also report impaired quality of life if they actually sense their atrial fibrillation. Because one of the problems is that many patients don't really know that they have AFib. Like many patients don't know that they have hypertension or diabetes. Some of them, of course, have palpitations and other irregularities which they sense, and then they go to the cardiologist. So now, how does it come to atrial fibrillation and hypertension? Well, hypertension has certain conditions, sequelae, as we call it. So the increase of thickness of the left ventricular wall, we call that cardiac hypertrophy or left ventricular hypertrophy. Then the stiffness, and I'll show you a little bit later on how this stiffness comes about. And then the diastolic dysfunction of the left ventricle. Hypertension can do all that. Think of HFpEF, cardiac failure. And then it goes a little bit further, and then you have an increase in left atrial pressure. The wall thickness is increasing in the left atrium, and other things happen in structural, I'll show you. And the left atrium enlarges. And this alone is already a possibility for atrial cardiomyopathy. And when you have this cardiomyopathy in the left atrium and in other parts of the heart, then you have a very complex structural and also architectural change in the heart, which then leads to disruption of the normal rhythmogenesis and conduction and opens up to sources of heartbeat that come from different regions of the atrium, for instance, around the pulmonary veins. In the OnTarget study, Paolo Verdecchia also did a study, a post-hoc study, and showed that when the blood pressure goes up, systolic blood pressure, and when the pulse pressure goes up, then you seem to have a correlation with the incidence of atrial fibrillation. Not true for the diastolic blood pressure. Well, this doesn't prove that hypertension is causing AFib, but at least we have a close relationship. And I promised you to show you a little bit what happens in the heart. If you go to the left bottom, you see normal heart structure. That means you have the cardiomyocytes, you have the fibroblasts, and you have the intracellular matrix. That's quite normal. When all these factors work on the heart, the pro-fibrotic factors work on the heart, then the heart changes, and this is on the upper left. And you see that the cardiomyocytes go bigger and are less. Then you have also a change of the fibroblasts into myofibroblasts, which don't do anything correctly. And you have also a thickening of the extracellular matrix. So the distances between the cells, the cardiomyocytes get bigger, and this makes the whole thing also stiffer with the profibrotic cells. And also you have a problem with the blood supply of each individual cell, cardiomyocyte. The factors doing that are all on the right of this, and I'm not going with you through all of them. But of course, there are all the candidates that we know, pro-fibrotic and pro-inflammatory factors that we have been researching about for many years. They all contribute with the genes that they enforce or produce to this stiffness and sometimes also to inflammatory reactions. And if you do a study, a so-called Mendelian randomization study, I'm not going to tell you how this works because I don't really understand it. But in summary, what the authors have found, despite potential limitations, the study provided the first evidence that the relationship between blood pressure and risk of AFib may be causal, suggesting that strict control of blood pressure might represent a long-term effective strategy to reduce the burden of AFib and its associated complications. Again, not 100% proof that hypertension causes AFib, but a close relationship and even a causality which is suggested. Now, a proof might come when you interfere. What happens if you strictly lower blood pressure? Can you prevent atrial fibrillation? Well, this is a very limited, with not too many patients, a study from Italy. And it showed that in this paper, in this study, yes, this was possible. When the blood pressure target was lowered to below 130 as opposed to lower than 140, then you see a significant decrease in the presence of atrial fibrillation, in the occurrence of atrial fibrillation. Again, Verdaccia, who has done this also with his friends in Italy, says, well, yes, but this is only a small study. We need bigger studies to really show a causal relationship. You see that I'm very cautious about that causality. So again, the question, does the RAS contribute to AFib? Well, yeah, probably it does, doesn't it? And would then the blocking of the RAS be helpful? Well, the RAS, you have seen that already, of course, contributes to all kinds of pathologies with the AT1 receptor, if inadequately present, and also to arrhythmia, showing with a thick red arrow. And again, this is a very nice diagram showing how angiotensin could actually do this job. And from top to down, you see a lot of factors that could be negatively regulated by angiotensin via the AT1 receptor, starting from the progression of coronary atherosclerosis, increase of myocyte volume, you have already heard about that, the interstitial fibrosis, which makes the heart thick and rigid. Left atrial pressure goes up, intracellular calcium comes in, and the refractory period of the atrium goes down. So there is more irritability of the left atrium. Ischemia comes, conduction abnormalities, and all that leads to electrical remodeling with new sources, generation of impulses, and finally atrial fibrillation. So angiotensin is certainly not the only factor, but it's important. Right, so if we go on then, there was a study by Fogari and his colleagues showing telmisartan versus amlodipine and ramipril in recurrent atrial fibrillation. And as you can see, telmisartan was significantly better than the others, ramipril in the middle, and amlodipine was the least effective in this respect. So at least there are studies which go into the direction that blocking the renin-angiotensin system by AT1 blockade can do something. And also review and meta-analysis, which has been done on 4 of these studies, shows a significant reduction of atrial fibrillation recurrence by treatment, in this case with telmisartan. Okay, fine to see that. Right, but we need more studies, we need bigger amounts, bigger numbers of patients. So can we prevent the dangerous sequelae of AFib, especially stroke? We need to avoid blood clotting in the atrium, because from there, as you know, the clots may shoot to the brain and cause a stroke. How can we achieve that? Well, we have to follow a strategy. And the strategy, which you can read up in many papers, is basically always the same. First of all, of course, you have hypertension without known atrial fibrillation. But you have a patient where you have a suspicion of alien atrial fibrillation. And a number of points may lead to this suspicion. For instance, an ischemic attack, cryptogenic strokes, and so on. Once you have this suspicion, you do a 3-step strategy. The first step is you do frequent opportunistic screening. If there is no AFib, okay, you don't have to do anything. The second is long-term non-invasive ECG monitoring, because you need it long-term. There may be AFib for a couple of minutes, and then not for a couple of hours, and then again, recurrent. And you don't get this if you just do an ECG of 2 minutes. Right, and if, again, no atrial fibrillation, forget it. Step 3, you can also implant a loop recorder. Again, no atrial fibrillation, forget it. If it's there, then you have to think about drugs that you can use. And of course, you have to use anticoagulants because you have a problem in the left atrium, which may shoot all these thrombus emboli into the brain. So, and then you go for this same ETT2R2 score. This is a very complicated score. It means that if you have one of the following, this counts. And it counts once or twice, according to the significance this of the following has. And for instance, it's female, it's over 60 years, it's a medical history of hypertension, diabetes, MI, and so on. So many, many patients will have at least 2 of these factors. Once they have more than 2, then recommendation everywhere is NOACs. And once they have only 1 or 2 or 0 to 2, then you can still give them warfarin or any other vitamin K antagonist. So what do we have in NOACs? Actually, the NOACs are also called DOACs, new direct oral anticoagulants or direct oral coagulants. Some societies rather want the direct oral coagulants because what is new in some years, right? So we have dabigatran, we have rivaroxaban, we have apixaban, and we have edoxaban. Dabigatran is the only one which directly inhibits thrombin. All the others inhibit factor 10. So a basic difference between dabigatran and the others. So how does it do against warfarin? And that is quite interesting. If you use a high dose of dabigatran twice a day, then you are better off with respect to stroke, and you're equal with major bleeding. And major bleeding and stroke prevention, this is the balance that you have to strike with any drug that is used in this respect. If you use the lower dose of dabigatran, 110, you have a better effect than warfarin in major bleeding, but the stroke reduction is the same. So again, the balance, high dose, low dose. Well, in Asian patients, the dabigatran was quite potent in the RELY study also. And again, the same thing, major bleeding and stroke. You see the high dose in this case was dabigatran better in both. But in the low dose, there was only an advantage in major bleeding, but not in the stroke. Yeah, again, so the question is, which dose do you want to use, the high dose or the low dose? So one of the differentiations that you can use is the age of the patient. If they are below 75 years, then we can use dabigatran 150. And because the advantage that you have in stroke reduction is actually better balanced against the hemorrhagic risk. If they are older than 75 years and have a high risk of bleeding for some reasons, then you would rather go for the lower dose. In kidney disease, in chronic kidney disease, you can actually use both if the creatinine clearance is still above 30 ml per min. But if you have really a problem with the kidney, with lower GFRs and so on, then probably you would go to the lower dose, 110. When compared to rivaroxaban and to apixaban, dabigatran was better than rivaroxaban in terms of several factors, and it was similar to apixaban using the same factors, using the same goals to measure. So basically, these all do the same. They reduce thromboembolism, but dabigatran does it by direct thrombin inhibition, and the others do it by factor 10. Right, there is a nice registry which is called GLORIA. And on this slide, you see the data from the second part of it, GLORIA 2, so to speak, with close to 2 million patients and 11 years and so on. So this was quite encouraging with low events, stroke, major bleeding, infarction, and vascular death. So quite encouraging. But that was not the end of the GLORIA trial. And the GLORIA trial has been finished now with phase 3, dabigatran versus the vitamin K antagonists, either warfarin or others used in other countries. And the conclusions, I just read them to you. Dabigatran was associated with a 39% reduced risk of major bleeding and 22% reduction risk for all-cause death compared with vitamin K antagonists. Stroke and myocardial infarction risk were similar confirming a more favorable benefit risk profile for dabigatran compared to vitamin K in clinical practice. And this was really a study, a registry done globally in clinical practice with more than 23,000 patients altogether globally, and not in selected patients in a clinical trial. So I think, yeah, if there is a high risk in these patients, and many have a high risk, then I would always go for a NOAC or drug and not for warfarin anymore. And also there is one particular advantage of dabigatran against the others, because you have an antagonist in your hands. So if there is a risk of high bleeding, or if there is an emergency operation that needs to be done tomorrow or today, you can really give one dose of this antagonist, which is very specific and which blocks the action of dabigatran within hours. And this is what the others don't have. So for that single reason alone, I would rather go for it, even if I have to give it twice a day, in the morning and in the evening, one dose. Right, so we come to the end. So what have we learned here? AFib is due to structural and functional changes in the heart, no doubt about that. Next to age, heart failure, and valvular heart disease, hypertension is a driver of AFib development. Whether it's the cause or not, but it's certainly a driver. Rigorous blood pressure lowering has been shown, I'm very cautious about that, to reduce AFib occurrence and recurrence. We need more studies on that. And telmisartan has been shown to reduce AFib. Also here, we would like to have confirmations in larger studies. Stroke can be prevented by NOACs. Dabigatran is superior to warfarin and rivaroxaban. If necessary, its actions can be blocked by a specific antagonist, and this is a major advantage over all the others. So again, well done, my friends. You have hopefully listened attentively, and I hope that you learned a little bit, and I thank you for your patience.
Thank you, Professor Thomas Sanger. Our next speaker is Dr. Janaka Kanaledi, who will take up the new approach to type 2 diabetes management and share important information and insights on the prevention of cardiorenal complications in type 2 diabetes. Dr. Kanaledi is a clinical reader in diabetes and cardiovascular disease at King's College, London, as well as an endocrinologist at St. Thomas Hospital, also in London. Please welcome Dr. Janaka Kanaledi.
So, thank you very much. It's my great pleasure to be in the Philippines again. It's my third trip. I'm always amazed by the kindness, the hospitality, and the welcoming nature of people in the Philippines. So it's a great pleasure to be here. So I'm going to speak about new approaches to the management of type 2 diabetes, and specifically in this very challenging, complex world where there are so many guidelines and so many choices. When I started medical school, diabetes only had 1 or 2 drugs to choose from, and now we have so many choices. And it's about where do DPP-4 inhibitors such as linagliptin fit in the modern management of people with type 2 diabetes. These are my disclosures. So I'd like to start with a picture of my hospital. This is what it looked like about 500 years ago. It was made for the poor people of London who could not afford healthcare. The church, charities created hospitals to look after people who could not afford to pay for doctors. And this is Guy's and St. Thomas's Hospital in London. It has changed over time, like many cities in the world. And I now work in one of these buildings, but unfortunately, it's not the beautiful building called the Shard, which is a 5-star hotel, and a Shangri-La. I work in the less elegant building to the right, which is still a tall building, but that's Guy's Hospital. I can see the Shard across where the other half, the better half, live, if you like. But I look after people with diabetes who have advanced kidney disease and cardiovascular disease, and I run clinics mainly for people on dialysis and transplantation with complications of diabetes. I also work at St. Thomas's. These are two hospitals that are joined together, and this is a nice morning walk where I have Big Ben guiding me, and we were talking about punctuality, and Big Ben never lies, so it's very good if the junior doctors don't turn up on time for the ward round. I have a second opinion that the clock that is always 100% accurate. And here I do clinics mainly for people with cardiovascular disease and heart failure. And we are very fortunate that we are well resourced. We are a very well funded hospital. People do not pay for healthcare in the UK, but many of our competitors say that the reason you are well funded is that the Parliament is opposite on, so that's the River Thames, and that's Westminster Bridge, and the nearest hospital to the politicians is St. Thomas's. It's less than 1 minute on ambulance, so there's a conflict of interest by location where we offer the best care in the UK. So what I want to really focus on is the 3 S's, and it's simplicity, safety, and success, and how linagliptin can offer this to people with type 2 diabetes. So managing people with diabetes can be challenging. We have to look at so many factors to decide the optimal therapy to give results in terms of HbA1c lowering, getting patients' diabetes well controlled, but we need to look at the impact on weight, the cost of medications, the side effects of medications, the long-term safety. And it's really about simplifying this approach, and something we can practically use therapies such as DPP-4 to simplify this rather complex and challenging scenario of looking at therapies for people with type 2 diabetes. So you have seen this slide before, and it's really about focusing also on prevention of complications. And we've heard about the key role of SGLT2 inhibitors such as empagliflozin that really have made a landmark change in preventing heart disease, preventing hospitalization for heart failure, and now the exciting data for preventing kidney disease. But where do DPP-4 inhibitors fit in this scenario of other therapies? And they still have a very important role, because what we do in diabetes, we start a therapy, but when the glucose level is suboptimal or we need to improve glucose level, we have the opportunity to add DPP-4 inhibitors on top of existing therapies, or where certain therapies may be contraindicated. So DPP-4 inhibitors such as linagliptin are a valuable resource that we have to improve glucose control, but also, as you will see, give us the confidence of using therapies safely in high-risk populations. So as you know, the father of modern medicine, and this is, apologies for my Latin pronunciation, but it's primum non nocere. And what this means is first, do no harm. The duty of a doctor, especially in lifelong conditions where people take medications for their whole life, is to give drugs that are safe and safe and safe. And this is the importance of therapies that we use for long-term chronic conditions. So a question to keep everyone awake. Which one of the following DPP-4 inhibitors has the broadest clinical trial evidence for cardiovascular and kidney safety in type 2 diabetes? So I think you have Slido, I hope, and we will give you a few seconds to try and answer the question. There's a beep. Okay, so it's a very conclusive answer, and the answer is, if you moved, is linagliptin. If we stop the voting now, and the answer is linagliptin. Cardiovascular and renal safety is only proven by linagliptin. And it's the simplicity that attracts me to linagliptin in the complex patients, but also in patients across a broad range of disease duration. It's one dose, 5 milligrams once a day. It can be taken in people with short duration of diabetes, long duration of diabetes, in the young person with diabetes, in the older person with diabetes. You can take it any time of the day. once a day across a broad range of people, irrespective of their body mass index, irrespective of their duration of diabetes, kidney function, and background anti-diabetic therapy. And as you will see in this slide, the group, if you like, with the most ticks, if you like, in terms of not only reducing HbA1c, but giving us the confidence of safety from cardiovascular outcome trials, as you can see across all these many DPP-4 inhibitors that we have, and we have new ones in Asia, in the UK and in Europe, and in the US, we do not have gemagliptin and teneligliptin because they have not passed the rigorous safety standards for the FDA and the EMA because they haven't done the cardiovascular and renal safety trials. But linagliptin, as you can see, has the evidence to support its use not just for glucose lowering, but also giving us the confidence of cardiovascular and renal safety on a single dose across a broad range of patients, irrespective of kidney function. And if you look at the reduction in HbA1c, all DPP-4s are pretty similar in how they work in terms of lowering of HbA1c. They are comparable in terms of reduction in HbA1c. What we do know is that in younger people in London, we have a huge problem of young people developing type 2 diabetes. And I was speaking with some colleagues from Boehringer Ingelheim. The youngest patient I have on dialysis with type 2 diabetes is age 34. Younger and younger people are developing type 2 diabetes at a young age, very aggressive phenotype. And what we have is therapies that need to work in the young, but also in the older, more frail patients. And we can see the benefits of linagliptin irrespective of the age in the younger person, but also in the elderly, more frail patient, we get good reductions in HbA1c. And also, irrespective of recently diagnosed person or someone who's had 10 to 15 years of diabetes, linagliptin consistently delivers reduction in HbA1c, irrespective of the duration of diabetes. And in people who are slimmer, people who are more overweight, and people who are more obese, irrespective of the body mass index, you can offer linagliptin to give a consistent reduction, and the benefits of reduction in HbA1c are independent of baseline, and that's why the p-value is there, is non-significant. There's no heterogeneity, so you still get the benefits of lowering HbA1c across a range of body mass indices. And what we know, and you saw this slide earlier, is that the efficacy of linagliptin is consistent across all stages of kidney disease. People with diabetes develop kidney disease. Nearly 1 in 2 people with diabetes will get kidney disease. And as diabetes progresses, so does the GFR drop. And here we have a therapy that consistently gives benefits for glucose lowering, irrespective of the baseline kidney function, and the simplicity of not having to keep changing the dose. You give the 5 milligram dose, and the patient continues on it, continuing to get the reductions in glucose and HbA1c reduction. Now, many people say, oh, why does it matter? Do we have to keep adjusting the dose? We can still use this dose. But what people forget is that DPP-4 is an enzyme and is present in every single cell in the body. So when you inhibit DPP-4, you're not only inhibiting in one cell, you're inhibiting it across all the cells in the body. And we need to be confident that we do not have off-target or on-target effects. And what we see here is that, sadly, a lot of people, this is in Europe, are using unlicensed doses of DPP-4 inhibitors in people with kidney disease, and we do not know the potential adverse consequences of using this. What we have from a recent trial is from Korea, which showed that the unlicensed use of DPP-4 inhibitors, so using without adjusting the dose of your sitagliptin or your saxagliptin or your alternative DPP-4 inhibitors, the unlicensed use is associated with greater harm. You have greater risks of hospitalization and greater risk of harm. So we should be using, in my opinion, always the licensed dose, and we should always be confident of the long-term safety of these drugs, which our patients take for years and years. So we know, and we saw this slide, that we do not need to adjust the dose. It offers the simplicity across a range of kidney functions. The single dose of 5 milligrams can be used with the confidence, as you will see in subsequent slides, confirmed by robust global cardiovascular and renal studies that gives us the confidence to use this therapy long-term in our patients with type 2 diabetes. I want to focus a little bit about hypoglycemia, fasting, whether for religious reasons or for health reasons. Many people now fast and use intermittent fasting as a way of losing weight. And whether you fast for religious or non-religious health reasons, we must be aware of the consequences of hypoglycemia if you have diabetes. And if you have a therapy like a sulfonylurea, which is not expensive, it is actually very expensive if you get hypoglycemia, and it's to be aware of the risks of hypoglycemia if you compare DPP-4s with sulfonylureas. It's not just the cost, it's the other costs that may happen if someone gets hypoglycemia while fasting. And in the Carolina study, this is the data from Asian patients studied in Carolina, which was a head-to-head comparison, as you heard so elegantly in the first talk, comparing linagliptin with glimepiride, 6 years of follow-up. What we see is that in Asian patients, the risks of hypoglycemia are 75% lower in linagliptin compared to glimepiride. 1 in 3 patients taking glimepiride had a hypoglycemic event, and linagliptin significantly reduces the risk of hypoglycemia at any level, but also severe hypoglycemia that requires assistance from someone else or potentially even hospitalization, which is very costly to the patient, but also to the wider healthcare system. So if you look at how we look at medications for diabetes, we must think just beyond the short term. We must think of the value that a medicine gives, not just the short-term cost, but what is the long-term value. The words sound similar, but cost and value mean different things. You may pay $200 for a full checkup of your car before you take a long journey across a desert, but it gives you the confidence that your car is going to be safe if you're traveling with your family. The cost is $200, but the value is thousands of dollars because you have the confidence of the therapy or the car working and not breaking down. So we must look beyond just cost, but what is the added value that therapies offer us in diabetes? So if you look at quality adjusted life years, which is a way of assessing value, what you can see here is that if you reduce HbA1c, you get long-term benefits, less complications, less damage to your eyes and your kidneys, improvement in symptoms, so you improve quality of life. If you prevent hypoglycemia, you get additional benefits, you feel better. Getting a hypoglycemic event is horrible. No one likes getting hypos. When you get a hypos, the patient often stop therapies and they feel terrible. And you get prevention of hypos improves your quality of life. If you reduce body weight, you have further benefits. And if you prevent cardiovascular disease, if you prevent mortality like with empagliflozin, your quality of life goes beyond the top end. Now you have a therapy like a sulfonylurea, which may lower HbA1c. You improve quality of life, but it comes at a cost. You have more hypoglycemia, you have more weight gain, and actually you're back to baseline. So we need to think beyond just glucose, but what is the added value of therapies that give us benefits for our patients? So I give this example of a taxi driver. For those who are familiar with London, this is the black cab driver, and they're quite wealthy. It's very expensive, black cabs. I use the train or the bus to go to work, but these people have a special type of license. And if you have a black cab license, an Uber license, a Grab license in the Philippines, if you drive a bus or a lorry and you have type 2 diabetes and you are on therapies like a sulfonylurea or insulin, by law, you are mandated to check your blood glucose. If while driving, you have an accident and the ambulance come and the police come and they find that you've had a hypoglycemic event and you have not been checking your glucose, you lose your license for 3 years. So it affects not just your glucose, but your choice of therapies affects your day-to-day activities. And we must think about the occupation of our patients. What do they do before we go for the simpler, less expensive therapy? If you're driving, you have to monitor your glucose every 4 hours if you're driving this type of vehicle, a public vehicle, which gives you the confidence that the person driving is safe. So this is important to consider, and patients have to sign this form, because if the patient has an accident and they they go to court and they lose their license and they lose their livelihood, they can say, oh, my doctor at Guy's Hospital never told me I have to record my blood sugar, but here we have to document that we gave this advice, because in a legal scenario, you have to give the best advice to your patients, be it a bus or a lorry. If I'm crossing the bridge at Westminster, I want to be confident that the buses and the cab drivers on these therapies are safe and doing the right thing. So if you look at the DPP-4 inhibitor class, and we have teneligliptin and gemagliptin, which I know are used in the Philippines, but remember, these drugs are not used in the rest of the world because they haven't passed the safety checks as well as the required assessments from cardiovascular outcome trials. So we start with teneligliptin. You can use it as monotherapy, that there is no evidence of its safety in heart failure or in people with kidney disease. There are some concerns with teneligliptin. With gemagliptin, there is no evidence at all in terms of kidney disease and no clinical trials at all. Vildagliptin, no evidence, no cardiovascular outcome trials or renal safety trials. Saxagliptin, there is some concerns, and my cardiologists do not use saxagliptin or alogliptin in people with heart failure because they haven't got the confidence of cardiovascular heart failure safety. Sitagliptin has safety demonstrated for cardiovascular disease and heart failure, but not for kidney disease. And at the top of the class, if you like, at the DPP-4 class, if you were to give a grade, at the top of the class sits linagliptin because of its cardiovascular, renal safety, confidence of using this therapy across a broad range of people. So in a rather complex world we live in, I think linagliptin simplifies the management. It offers a simple, effective way of reducing glucose, but also across a broad range of people with type 2 diabetes. It reduces HbA1c, and it is the only DPP-4 inhibitor that has a cardiovascular and kidney safety profile demonstrated, as you will hear in my next short talk, across a unique, robust, global cardiovascular outcome trial program. And it is an option that we should consider more and more as add-on therapy or as monotherapy for people with type 2 diabetes. So thank you very much for your attention. So after a brief pause, we will move on to the second part. And it's really about complications and how we can improve and prevent kidney and cardiovascular complications. So I show this diagram to tell us that, as you heard from the previous lecture by Professor Unger, I see the heart and the kidney as being partners with diabetes in this kind of combination. They have a synergistic, complementary, but also they're like a happy or unhappy marriage. They're connection together. If one goes worse, the other gets worse. They're connected. If you have kidney disease, you will have heart disease. If you have heart disease, you will have kidney disease. And having diabetes just complicates this because of all these pathophysiological processes, from activation of the renin-angiotensin system to salt and water retention. There's intricate pathophysiological processes that drive combination of heart and kidney disease in people with diabetes. And what we know is that, unfortunately, it is common. As I said, 1 in 3 people with type 2 diabetes will have cardiovascular disease. The global data would suggest that actually 1 in 2 people, it is 40% here, 1 in 2 people will have kidney disease, and 15 to 20% of people with diabetes have heart failure. So although we have these unique pathophysiologies, when the patient comes to us in the clinic, they are one person and they have all these conditions within themselves, and we need to look at that in that holistic way, but be aware that heart and kidney disease are very common and they sit within the same individual. And if you look at common admissions and diagnoses, kidney disease, heart failure are the commonest manifestations, even in people who have well-controlled glucose. So we need to think beyond the glucocentricity. Even in people who have good control of HbA1c, they still sadly have heart failure, kidney disease. And in our hospital, the people who spend the longest on the wards are patients with foot disease. And then after that, it's the patients with heart failure who keep coming in and into hospital and out and back again. And once you have heart failure or kidney disease, this has a huge impact on your quality of life, but also on the health economics and the cost of healthcare. So we know that we have to have a multifactorial approach. We talked about antihypertensive therapy. Lifestyle is so important in terms of diet, exercise, salt reduction, lipid lowering, smoking cessation. Smoking is bad for the heart, but did you know it's also terrible for the kidneys, and it's devastating for the eyes of people with diabetes. People who smoke will have progressive hypoxia and lose eyesight at a faster rate than people who do not smoke. So it's not just the cardiovascular impact of smoking, but the impact on the eyes and the kidney. And then we have these new therapies that we add on to RAS inhibitors. You all know the SGLT2 inhibitors that really help people prevent kidney disease and heart disease. So you heard about hypertension, blood pressure, type 2 diabetes, kidney disease, these all interconnected. And you heard about the value that telmisartan offers in terms of simplicity and effectiveness and 24-hour coverage with good data for organ protection. And in parallel, linagliptin also offers benefits for the kidney. Blood pressure is one of the most important factors for kidney disease progression. And here we see this is proper GFR. This is not eGFR. This is old-fashioned proper GFR measured by chromium EDTA. What we see here is the loss of GFR per year. So if you have poorly controlled blood pressure above 170, your patient is losing 10 mils per minute per year. They can drop from 40 to 30 mil of GFR in 1 year. So controlling blood pressure is one of the most powerful tools we can offer, not only for the stroke and the cardiovascular disease, but also to protect the kidney. Once you have a patient with chronic kidney disease, managing glucose can be quite challenging. Many drugs, you have to adjust the dose. You heard about metformin, you heard about the other DPP-4s, which you have to adjust the dose because drugs are eliminated by the kidney. This is one of the key functions of the kidney. As your kidney function declines, your clearance of insulin drops. So once your GFR goes below 20, if you're injecting insulin, your insulin stays in your body for 30 to 40% longer, has a longer effect, and you're much more likely to get hypoglycemia. So if you have advanced kidney disease, you have to look at reducing the doses of insulin, which is in your body for longer. When you have uremia and acidosis, this makes your body more insulin resistant. And many people forget the importance of the kidney to make glucose. The two organs in the body that make glucose are the liver and the kidney. And if you do not have kidney function and you have advanced kidney disease, you do not make glucose. So these patients are at very high risk of hypoglycemia because you cannot produce glucose to compensate when it's required. And we know that it can be challenging, and we should really avoid hypoglycemia, which is very common, and also many of our patients have heart disease. And what this slide shows is that once you have chronic kidney disease and diabetes, your risks of hypoglycemia are nearly double compared. So the strongest risk factors for hypoglycemia are obviously using drugs like sulfonylureas and insulin, but it's your age and your kidney function. And once you have kidney function failure, your risk of hypoglycemia is nearly double. So if we have a complex case here, I've chosen a complex patient with heart failure with preserved ejection fraction. He's 67 years old. He has diabetes for 12 years. He's got CKD. He drives a taxi. He's not keen on injectables. These are his current medications for his heart failure. And he's got diabetes. He's on metformin. So he's got type 2 diabetes, he has heart failure, he has kidney disease, he drives. These are his HbA1c. It's risen over the last year. His blood pressure is relatively well controlled. His kidney function is stable. And the question is, in this person with heart failure, he's already on empagliflozin to give him the heart and kidney protection. So what do we add on next to improve his HbA1c? He's got the platform of empagliflozin. We do not stop it. We continue the empagliflozin because of its cardiac and renal benefits, but we see that his HbA1c has risen and he has chronic kidney disease, and we need to improve his glucose. And the question is, what next? And I think it's a free text, so hopefully short answers rather than long answers. What would you do next in terms of a suitable next therapy for his diabetes? HbA1c rising, already on empagliflozin. What should we do next? What are the choices in terms of therapies? So it's either you could look at adjusting his dose of metformin, which I wouldn't do. You could add injectables, you could add sulfonylurea, you could add a DPP-4 inhibitor. And really, it's the role of DPP-4 inhibitors in this scenario in terms of not only intensifying the treatment, but offering a safe and successful way of doing it. So if we move to the next slide. So what we have here is someone on a SGLT2 inhibitor. We want to improve their glucose. And what we do is we continue the empagliflozin, but we add on the DPP-4 inhibitor like linagliptin that gives us the confidence of long-term safety. And why do we choose linagliptin? Because as I said, saxagliptin, alogliptin, gemagliptin, teneligliptin, sitagliptin do not, in my view, meet the standard for cardiovascular and renal safety. And these are the drugs I would avoid using, and I would prefer to use linagliptin because its simplicity. You can use it across all ranges of kidney function, but most importantly, I have the safety data that we will see next of long-term kidney and cardiovascular benefits as well as safety. So I'm going to briefly summarize these two key trials very briefly. If we look at the trials for Carmelina, which was a high-risk population with chronic kidney disease, safety in terms of cardiovascular outcomes. You do not see gemagliptin, you do not see teneligliptin on this slide, or vildagliptin, because we have not had the cardiovascular outcome trials to demonstrate cardiovascular safety. If you look at heart failure, you can see that we avoid saxagliptin, we avoid alogliptin because they may be associated with the increased risk of heart failure. But in Carmelina with linagliptin, we have the confidence that it's safe and does not cause any harm to high-risk patients like those with kidney disease. And this is some interesting data from Carmelina. This is hospitalization for heart failure. So I was speaking with one of your colleagues from who works in Philippines, and I see younger and younger patients, especially of Asian origin, often Filipino healthcare workers who have moved and worked in London, presenting with heart and kidney complications. And if you're Asian, your risk of heart failure and kidney disease is nearly double someone who is Caucasian, and you get it at 5 to 10 years earlier. And in this small study, a sub-analysis, we can see hospitalization for heart failure in Asian patients was actually lower with linagliptin in the Carmelina study. And also in those who did not receive insulin, you see some benefits for heart failure hospitalization in a sub-analysis of the Carmelina. Small numbers, but important nonetheless in a high-risk population of people with kidney disease, diabetes of Asian origin who were evaluated in Carmelina. So when I show this slide, people think there's an error on the slide. There isn't anything that's been missed. The reason there's a big question mark is those other drugs do not have the kidney data. They do not have the confidence of renal safety. The only DPP-4 inhibitor that has renal safety is Carmelina in the Carmelina trial, where linagliptin demonstrated benefits for albuminuria reduction, but also confidence in renal safety. And in Asian patients, you see the same benefits. You see the benefits for hospitalization for heart failure, but also the reassuring renal safety in Asian patients studied in the Carmelina trial where linagliptin was used. So the kidney and cardiovascular safety is robustly demonstrated here in this trial of Carmelina, which is one of the, if you were to do a trial of high-risk patients, I always say, come to my clinic. The kidney patient is the patient who has lots of heart failure. They're the patient who has lots of complications. So if you can demonstrate safety in a kidney patient, you are very confident that this is a safe drug in lots and lots of high-risk patients, because the kidney patient, sadly, has lots of complications and reduced life expectancy, high risk of heart failure, high risk of hypoglycemia, high risk of everything. But here, linagliptin demonstrates safety in a very high-risk population, gives me a lot of confidence to use this therapy in day-to-day practice. So again, you can see that the benefits, we saw this data earlier, HbA1c reduction continues irrespective of the kidney disease with the same 5 milligram dose that you can take once a day. So we saw this in terms of the kidney outcomes. The albuminuria progression is quite important because we can see in a high-risk population that reduction in albuminuria on top of an ACE inhibitor, on top of other therapies, you get these benefits of linagliptin in reducing albuminuria developing and progressing, albuminuria is a biomarker of kidney damage, and one would hope by lowering albuminuria, this is very good. It's an early sign. We don't have the long-term data for kidney failure, but it's a good sign that the kidney is being protected by the effects of linagliptin, preventing albuminuria from getting worse. And we look at Carolina again very briefly, and I will just highlight risks of hypoglycemia and also the safety in the Carolina study. This is patients who were evaluated over 6 years. It's the longest trial for DPP-4 inhibitors, and it's the only trial that compared DPP-4 inhibitor with another drug called an active comparator. So in this study, we have the confidence of cardiovascular safety, but we can also see benefits for hypoglycemia. You saw this slide earlier, the 75% reduction in hypoglycemia. If you translate this to numbers of events, you're preventing 50 to 60 hypoglycemic events per 100 patient years. So this is not a small number. You're actually preventing hypoglycemia in the daytime, in the nighttime. 1 in 3 patients on a sulfonylurea will get hypoglycemia, and linagliptin offers a 75% reduction in hypoglycemia in this population. So we have the confidence of clinical trials from Carmelina and Carolina, so the real-world experience of using this drug in more than 30 million person years. The drug has been around for just around 10 years, and it offers us a unique option of giving our patients a safe, successful, simple treatment to really improve outcomes and improve quality of life. So a summary, if you like, and again, linagliptin remains the best student in the class, if you like, in Dr. Anger's class. It's at the top of the class because of these benefits that we see, not only for glucose lowering, but the cardiovascular and kidney safety, the ability to use it across a broad range of patients, from early disease to late disease, with or without kidney disease, irrespective of body mass index or age, a single dose offering simple, safe, and successful treatment for people with type 2 diabetes. So to conclude, it's proven in terms of its success in lowering HbA1c. It's the only DPP-4 to have cardiovascular and kidney safety. It is flexible, it is simple, you can use it across a broad range of patients. And remember the 3 S's for linagliptin: simplicity, safety, and success in managing people with diabetes. And in this very complex world we live in, simplicity, in my view, is the ultimate sophistication. We often complicate life. We complicate day-to-day things, and simplicity is key. And linagliptin offers you simplicity, safety, and success in managing patients with diabetes. Thank you so much for your attention.
Thank you, Dr. Janaka Karalady. We will now have a panel discussion and Q&A. Please be reminded that if you are joining us online, you may send in your questions using the Zoom Q&A button at the bottom of your screen. If you are joining us on site, you may continue to send your questions by using the Q&A tab on slido.com. In your browser, go to Slido and simply type the event code BICVM or scan the QR code flashed on screen, and then proceed to the Q&A tab. Gracing the panel discussion with his expertise is Dr. Oscar Naidas. Dr. Naidas is past chairman of the Department of Medicine, St. Luke's Medical Center, Quezon City, and past chairman and associate professor of the Department of Medicine, St. Luke's Medical Center, College of Medicine. Let's welcome Dr. Oscar Naidas, along with Professor Thomas Anger and Dr. Janaka Karalady. The panel discussion and Q&A will be moderated by Dr. Bien Matawaran.
Thank you very much again. So welcome to the panel discussion. You can again forward your questions using the Slido app. as we'll address our two speakers and of course, Dr. Naidas for his reaction. So I don't have any questions yet in the slide though. Let me probably ask Dr. Naidas first because as a nephrologist, let me just say that you probably will be the victim of uncontrolled hypertension and uncontrolled diabetes. Can you give us a short takeaways from the talk of Dr. Unger with regards to telmisartan, and of course, Dr. Janaka with regards to use of linagliptin, no, in patients, for example, with hypertension and diabetes with regards to the consequences in the kidneys?
First, just to recall the presentation of Professor Hanaka on the relationship of blood pressure control and the rate of decline of kidney function. So it's very evident that if we do not control the hypertension, you have a faster rate of decline of kidney function, reaching end-stage kidney disease, requiring dialysis or kidney transplantation. And thus, that's very important. And as a follow-through, the presentation of Professor Unger, of all the blood pressure pills that are available to us, it appears, it's very evident that an ARB, although it is same effectiveness as the ACE inhibitors, ARBs would have the advantage of its being more tolerable. And if it's more tolerable, patient will stay on this ARBs, particularly telmisartan. And that leads to a better blood pressure control. And the long term, it will prevent faster rate of decline of kidney function. And of all the ARBs, there was overwhelming evidence that telmisartan outperforms the other ARBs. What I do remember is the reduction of albumin excretion is far better in the telmisartan therapy compared to losartan following the Amadeo trial, wherein they compared telmisartan and losartan among patients with hypertension. Their blood pressure was more than 130 milligrams, and their baseline urine protein creatinine ratio is 700. So at the end of a year, there was more reduction of albumin excretion, about 30% in the telmisartan group versus 21% in the losartan group. So you have to have a better blood pressure control, and to achieve that, you have to use a very long-acting ARB, telmisartan, which also will cause a significant reduction of the albuminuria, at least 30%, because that's the key number. You must achieve a 30% reduction of the albuminuria in order to equate a significant reduction of important clinical outcomes like dialysis and kidney transplantation.
Okay, thank you very much, Dr. Naidas. So before we answer the questions here in Slido, I'll go back to the patient case for a bit and probably ask questions to the three panelists. So for Professor Unger, so the patient case that I've shown you was on losartan, so 50 milligrams twice a day, and I opted to shift that patient to telmisartan at 80 milligrams. So since we are a mix of primary care, of family physicians and endocrinologists, is there an issue with regards to how to shift the medications with regards to timing of those? So meaning, does it really matter if you start, for example, your telmisartan in the morning or in the evening? If you because that patient was also on amlodipine, do you need to split the dose, meaning one in the morning, one in the evening, or it really doesn't matter? Because there are even fixed dose combinations of telmisartan and amlodipine, right?
Yeah, now this is working. Well, evening or morning dosing. This depends and has been shown very nicely with the calcium blocking agents. if you use very short acting like nifedipine or nitrendipine, then you are better off if you give a morning and an evening dose. That has been shown in many trials. But if you use a long-acting calcium antagonist like amlodipine or lercanidipine, you can use a morning dose and that's enough. You don't have to give an evening dose. The same is similar for the ARBs. Losartan is relatively short-acting, so 2 doses of 50 would be rather preferable to 1 dose of 100 in the morning. With telmisartan, as I have shown, even after a forgotten dose on 1 day, the next day, you still have the lowering of blood pressure of, let's say, 8 millimeters of mercury or so. So it stays down, and it's what we call a forgiving dose. So you don't have to give it in the evening. 1 dose in the morning is enough in this case.
Yes, Professor.
Yeah, so I think it's also offering the flexibility. I think the most important thing is the patient taking the tablet. Number one, whether they take it in the morning or the night, they have to first take the tablet. But for the kidney patients, I also worry about that escape of the blood pressure overnight. So we may give telmisartan in the morning, but we may also give amlodipine in the evening, just to make sure that early morning surge is controlled. And when I'm trying to get very good blood pressure control, I find that a lower blood pressure is better tolerated through the night when people are lying in bed and asleep. And if they're working in a hot country or they're working on their feet, it may be better then to sometimes dose the blood pressure if you're trying to get to 130 over 80 or below. So I often use nighttime dosing, but it's whatever time the patient takes the tablet is first and then the next step.
Yeah. Especially more so for very hot countries like the Philippines, right? Yeah, Dr. Naidas, any comment on how you do the dosing for example, telmisartan and amlodipine?
Just to agree with Professor Tanaka. It doesn't matter whether they take it in the morning or the evening, as long as the patient takes it. And if he takes it in the morning, he takes it in the morning. Then that is supported with the time trial recently published in the Lancet. Shows that take it in the morning and the evening, it doesn't matter. The same cardiovascular benefit.
Okay. So again, going back to the patient case, to Professor Janaka, with regards to, you've mentioned several times hypoglycemia. So in the case that I presented, she was initially on glimepiride and actually shifted to linagliptin. How important is it for those patients who are at higher risk? So she's 65 and she has CKD, right? So why should we be afraid of hypoglycemia aside from just the symptoms, right?
So if you speak to patients or you've had a hypoglycemic event yourself, it's horrible. Number one, no one likes getting a hypo. You feel like your life's going to end. Your heart goes faster, you sweat, you get dizzy, you can have a fall. And you feel bad, number one. Patients who feel bad after taking medicine stop lots of medicines, even the good ones. So we need to prevent hypos for how patients feel. But also, hypoglycemia is bad for your heart. And when you have kidney disease, or even if you don't have kidney disease, if you have type 2 diabetes and you drop your blood sugar, your QT interval prolongs, you have cardiac arrhythmias, your plaques and your thrombus, all these other processes get worse. So hypoglycemia is terrible in terms of how you feel and your quality of life, but also long-term it has cardiovascular events. And also if you're driving or you're working and you collapse and you fall on the road, there are unintended, hopefully these things never happen, but in the real world, they do happen. And it's to prevent those unfortunate consequences. And if you have kidney disease, your risk of hypoglycemia is 2 to 3 times greater than if you don't have kidney disease.
The cardiologist is raising his
Well,
hand.
I agree on all of that, but my question as a non-diabetologist, why do we still use sulfonylureas? Why do we still, in hypertension, we don't use reserpine, we don't use guanethidine and all those ancient drugs, which were helpful in the beginning 40 years ago. But now we have better ones. And why don't we just skip the sulfonylureas?
I think it's because we have to be conscious of the economic climate of the world and the cost of medicines when people pay out of pocket. And sulfonylureas are less expensive and they're the least expensive compared to modern drugs. But what I wanted to highlight in my talk is don't just think about the short-term cost. Think of the value of the medication, because it may appear cheaper. If you have to monitor blood glucose, if you have to do extra blood glucose test strips in the UK, blood glucose test strips are expensive. And they're not cheap in other countries as well. So there is additional costs. And if you get admitted with a hypoglycemic event, the ambulance costs money. Coming to the hospital costs money. If you have to stay overnight, it costs money. So think beyond just the cost of the medication, but of the value of the medication. And I agree, we think about cost, but not always the value when we choose drugs.
I think that's very important, because even in the ISH, you mentioned about optimal and essential treatment. So I think in diabetes, we also should somewhat individualize with regards to resource settings, now with regards to what are the recommended medications for such. We'll probably try to address the questions in the Slido app. So we have the first question. Can you flash the first question on Professor Unger? How long can DOACs be used in patients with newly diagnosed AF?
Well, I could make it short, lifelong. Because the problem is silent AFib. AFib that is patent, which you don't see on a normal ECG, but which is still there and may have a recurrence here and there. And if you don't have this patient on a NOAC, in this case, you don't know when AFib is coming and going on a normal basis. So you really have to, it's the problem that we always have with preventive measures. Because if nothing happens, no stroke, you say, oh, that was due to my preventive measures. But if you stop doing it and a stroke comes along, then you regret it, because you should have done preventive measures with the NOACs.
So I think I'll just add to say that it's important to find out what the cause of the AF is. Someone who's newly diagnosed, there may be a reversible cause, and often in many countries we would offer electrical therapy in terms of reversing the cause, but there are also modifiable causes of new onset AF, and it's important to clarify that diagnosis before putting someone lifelong, because it may be a reversible condition so if you don't look for it, I always tell my juniors, you will never find it. So you have to look for the reversible causes.
That's true. But even if you reverse it for a while, there may be a recurrence. And that's the problem.
So we'll continue asking the cardio question to you, Professor, on use of flecainide as a pill in the pocket for AF. Yeah.
Actually, most, if not all, antiarrhythmics have been tried. And to my knowledge, the only reasonable stuff is if you do a electrical reversal and then after that you use amiodarone. And sometimes amiodarone helps if you load it with a high dose and then go to a low dose for a certain time. But you're never sure whether you can prevent atrial fibrillation with that. So basically, we don't really have good drugs at present that are devoted to reduce or even to prevent atrial fibrillation. Although with rigid blood pressure lowering, we can do something in this direction.
Okay. So we'll take the next question probably to Dr. Naidas as well as Professor Janaco on use of telmisartan in patients with elevated, that's above normal urinary albumin creatinine ratio, but with blood pressure of 120/80. So ARBUs for patients with above normal ECR, but normal blood pressure. Professor Janaco.
So I think this is a very, very good question. It depends on other factors. How old is the patient? Are they frail? What are their other coexistent risk factors? Do they have CKD? Are they high risk of stroke, etc.? But let's assume those are clarified. My reading of the literature is that your blood pressure and your albuminuria reduction dose response curves are different. So you reach a threshold for blood pressure reduction with the ARB, but sometimes the higher dose continues to deliver albuminuria reduction without further falls in blood pressure. But obviously we have to worry about hypotension. In my view, albuminuria is a risk factor not only for the kidney, but for the heart. And in that situation, what I would do is add a SGLT2 inhibitor like empagliflozin, and rather than trying to push the blood pressure, potentially lower or doubling it. So I think in that scenario, to answer it in an indirect way, is add a SGLT2 inhibitor, but the two curves are different. You get doubling the dose, reach a point for blood pressure, but continuing to increase the dose, you get further reduction in albuminuria, but hypotension is a risk.
Serious. Yes, Professor Angar?
I think you're just touching a dilemma that we have with the ACE inhibitors and the ARBs. Both have a relatively flat curve, as you say, in reducing blood pressure. So for instance, if you go from telmisartan 20/40 to 80, you can reduce blood pressure a little bit more, but not much. So the curve is flat. But if you go for organ protection, including the kidney, but also heart, stroke, and whatever, then you really need the high doses of the ARBs and of the ACE inhibitors. That has been shown with ramipril, has been very nicely shown with losartan, ELITE-1 and ELITE-2 study. ELITE-2 was not successful because the dose of 50 milligram losartan was used in cardiac failure patients and it did not work significantly. Telmisartan 80 was good for on target. I was actually trying to convince Salim Yusuf in those days to use 160 telmisartan. But then he said, well, that would be nice, but in many countries, we cannot use 160 because the doctors don't want it. Doctors don't want high doses. Yeah. But the blood pressure wouldn't be reduced much more.
Yeah, right. We must recall that the Flowsin trials were on the background use of an ACE or ARB that's maximally tolerated. So if you want to give an ARB for a patient who has consistent elevated ACR, urine ACR, even if the blood pressure is now 120/80, you can still give it, provided that you again be cognizant of the hypotension, and the patient should be educated on this. And it's very important because after reduction of urinary albumin excretion, it's for organ protection.
Yeah, I was about to ask you earlier when you mentioned about comparison on kidney outcomes of losartan, especially albuminuria versus telmisartan, that the benefit was shown that is independent of the blood pressure lowering. I think we have to specify that the benefit of telmisartan versus losartan was actually independent of the blood pressure lowering, right?
They achieved the same blood pressure control.
Okay, so I think we also have a question. Professor Janaka, is it safe to use linagliptin as first-line medication for young, newly diagnosed type 2 diabetes?
Yes.
Yes. He actually said that it is a good drug for a broad range of...
And also some patients, in my experience, the younger patients are not very good taking tablets, generally, who have busy lives, and trying to get them to take metformin 2-3 times a day. They don't eat regularly. If you take metformin, you have to take it after your food on a full stomach. It's a bit complex. You can use slow release. So I think the first thing is compliance, and the fact that you can take linagliptin any time of the day offers simplicity, and it doesn't cause hypoglycemia, so you would use it in preference to a sulfonylurea. But obviously metformin is recommended as long as the patient takes it, or if they can't take it or don't want to take it, then you would give linagliptin.
So you mentioned earlier that you also see a lot of Asian patients in the UK, because I don't know if you see the same thing, because there's data, at least in Asian population, in Asian cohort, that actually DPP-4 inhibitors are actually more potent when given among Asians versus, for example, Caucasians. And do you see the same thing?
For sure. So, one of the advantages of working in London is the multicultural population. So I have patients from the Philippines who have come in recent years, but people from Hong Kong, from Vietnam. And in patients of Asian origin, DPP-4 inhibitors are far more effective. And that's why in Japan, for example, first-line therapy is a DPP-4 inhibitor. And also they're more intolerant of drugs like metformin. So if I have an Asian patient, I would offer a DPP-4 inhibitor like linagliptin first. I think patients' ethnicity and heritage influences how people respond to drugs.
Okay, so we have a question here. I don't know if you'd like to answer this, Professor Unger, on giving two different antihypertensive medications on alternate days. So since probably we've been talking about long-acting antihypertensive agents, some would probably give alternate days of telmisartan and amlodipine. Comment on this?
The only answer I can give, please don't. Please don't. I mean, is it Monday and Wednesday? Oh, when did I have to? So patients will forget everything about it, and this results in stopping the medication. You know, this is deleterious. Please, please don't. Give them a single dose combination, if possible, and there are many on the market now, and that can be given in the morning, every day, lifelong. That's what it is.
Okay, so as we say in the Philippines, my forever, no, for hypertension management, and that is taking your anti-diabetic medications. Okay, so we'll ask question number 2, probably to Dr. Naidas or Professor, on the use of, because you've shown earlier the DPP-4 inhibitors. At least in the Philippines, we have teneligliptin and gemagliptin. One of those two medications have actually a high renal excretion, and yet they claim that they can be given once a day.
So we don't have termigliptin or teneligliptin. It's not available in the US or Europe. And I've looked at the pharmacokinetic studies, and they're from 6 or 7 patients, and they look at the area under the curve after exposure to the drug in someone with stage 5 kidney disease. So generally, if you're renally excreted and you've got kidney failure and you give a drug, the drug stays in your body for longer. You need to reach a threshold of 2, the area under the curve, after the dosing to have mandated dose reduction. The teneligliptin and gemagliptin reach about 1.8, 1.9, just about, but linagliptin doesn't reach that high level because it's not renally excreted. So as I said, DPP-4 is an enzyme in every cell. It's in your white cell, it's in your beta cell, it's in your heart cell. Why do you want to give a drug that may have off-target, unsafe effects if the dose remains high in kidney disease? So I think my view is safety, number 1, and that's why I would use linagliptin as a preference, because the other drugs don't have the evidence from pharmacokinetic studies, but also the clinical outcome data for clinical confirmation.
Dr. Naidas?
Yeah.
Agrees with Professor. Okay, so we'll take question number, but I'd like to somewhat, so question number 2 is there a role for more potent ARBs like telmisartan in mild or treatment-naive hypertensive? So I'll probably rephrase that question, because probably for those patients who just have hypertension, because I think as you showed in your slide, particularly for the high-risk patients, high-risk for cardiovascular disease, the evidence is compelling for telmisartan, so that some would actually start patients just hypertensive, not of high cardiovascular risk, with less potent antihypertensive medications like losartan. So is that?
Well, I think we have to distinguish here what kind of patients we have in front of us. There are some patients who run about with a slightly elevated blood pressure. Well, in the United States of America, even if they run along with 132 over 82, they're already hypertensive, and something has to be done. But let's look to the rest of the world. Let's say a patient has just 145 over 85, something like that. Say, well, life changes, lifestyle, eating behavior, and so on doesn't really work. In many cases, it doesn't work. So I have to resort to drug treatment. What do I do? And in this case, you could really start with a monotherapy. And no matter, I would start with 80 milligrams of telmisartan or corresponding dose of another ARB if somebody wants or ACE inhibitor. And the other group of patients, as I mentioned in my talk, and it's also in the guidelines, is the very old patients above 80 years and frail, and then you don't want to have a precipitous blood pressure in the beginning. But that's actually the only two exceptions, and otherwise, I don't see any. And as I say, the dose response curve is relatively flat with blood pressure, but you have to go to the higher doses of sartans and ACE inhibitors to benefit the patient with respect to the organ protection. And you have to remember that if somebody develops hypertension, there is a story before that. And there are already structural and functional changes in the vessels, maybe even in the heart, starting left ventricular hypertrophy and so on. And why not try to prevent these changes, which eventually lead to hypertension or kidney disease and so on. So starting early and looking that blood pressure is really controlled very early on, even if somebody has only mild hypertension.
Okay, Dr. Naidas. So we're actually over time. So we'll probably ask our two panelists short takeaways, no, with regards to hypertension, diabetes, and of course, as I've said, the victims of uncontrolled hypertension and diabetes. Dr. Naidas, our nephrologist. Dr. Naidas, takeaway.
Okay, so control blood pressure, control good glycemic control. You use the best available drugs, and don't forget to add the Flozin.
Okay, Professor Janaka.
So I think remember the 3 S's of linagliptin: simplicity, safety, and success for a broad range of people with type 2 diabetes.
Professor Unger.
Well, I agree with everything you said, but follow the ISH guidelines, and then you will be happy for the rest of your life with your patients.
Okay, thank you very much. So can we give a round of applause to our three panelists? Thank you very much for your time. No? And with that, okay, let us call our partners from the PAFP a reaction from Dr. Limuel Abrogena.
Thank you, Dr. Matawaran, and to our expert panelists. To share his reaction, may we call on stage Dr. Limuel Anthony Abrogena. Dr. Abrogena is a member of the Philippine Health Technology Assessment Council. He's the current Executive Secretary and a member of the National Board of Trustees of the Philippine Academy of Family Physicians. He is a full-time associate professor of the Ateneo School of Medicine and Public Health. He is also currently affiliated at the AMUSUC Seamen's Hospital, Department of Family and Community Medicine. Please welcome Dr. Limuel Anthony Abrogena.
Good evening, everyone. Thank you to our two speakers, Professor Unger and Dr. Caraliede, for their informative presentations and the insights shared by Dr. Matawaran and Dr. Nadias. Tonight, we have increased our knowledge, skills, and know-how to deliver essential, high-quality services with the use of the RAS inhibitors telmisartan and DPP-4 inhibitors linagliptin for the prevention and management of cardiometabolic diseases and other non-communicable diseases. Despite advances on the front of cardiometabolic pharmacology, novel evidence-based cardiometabolic drugs initially approved for the treatment of hypertension and diabetes have proven to treat not only these two cardiometabolic diseases, but has proven benefit to its sequela of uncontrolled diseases such as atrial fibrillation, heart failure, and chronic kidney diseases. Two exciting recent developments in the approach to and our understanding of cardiometabolic diseases from a clinical standpoint. First, lifestyle strategies can't be something short-term, and that Very restrictive programs may cause permanent negative changes in the metabolism. And second, pharmacologic treatments can now be designed that are easier to live with than ever before. Primary health care is a critical component in the fight against non-communicable diseases. Cardiometabolic diseases such as hypertension and diabetes represent the largest disease burden among non-communicable diseases. Primary health care can enable the provision of long-term, people-centered care, which is sustainable, accessible, and affordable. Primary health care also allows an opportunity to undertake activities for the promotion of healthy lifestyles and prevention of cardiometabolic diseases through a life course approach from the prenatal period to an older age. Primary health care targets modifiable risk factors, promotes healthy lifestyle habits, and provide continuity of care across the lifespan. We primary care physicians have the advantage of building trust with our patients and their families that is grounded in shared decision-making for all drug and non-drug recommendations. Understanding patient perception elucidate factors which may influence overall utilization of these interventions. Adherence to these recommendations is anchored to the trust our patients have to us, their partners in healthcare. Addressing non-communicable diseases burden requires a primary healthcare focus, providing a people-centric, comprehensive, integrated, and equitable care built on the principles of universal healthcare. Sustained efforts are needed to rapidly scale up NCD services to readjust primary healthcare to attain transformative changes, integrating NCD control at primary healthcare system to achieve national non-communicable diseases targets. This will require additional investment in prioritizing competent health workers, essential medicines and diagnostics, and a good information system, which are essential components of credible primary healthcare system. Thank you very much.
Okay, thank you very much. So let me close tonight's activity by saying that our experts have given us insights on how to manage diabetes as well as hypertension. However, there are still gaps with regards to treatment in spite of the available therapies for hypertension and diabetes. And we've learned tonight that to close that gap, that we can make use of an ARB like telmisartan, which has proven efficacious in patients with hypertension, with and without high cardiovascular risk. And of course, close the gaps with regards to diabetes management by using a DPP-4 inhibitor like linagliptin. And of course, we've learned that it is a simple anti-diabetic agent, very safe and efficacious, that can be given in a broad range of patient population. And with that, we'd like to thank again our panel of experts and of course you, our participants here in Marriott, as well as our participants online for bearing with us. And of course, thank you very much to our partners, Boehringer Ingelheim, for your continued support for continuing medical education. To everyone, good night and be safe, be well. Thank you very much.
Thank you, Dr. Bien Matawaran, Professor Thomas Unger, Dr. Janaka Carilini, Dr. Oscar Naidas, and Dr. Limuel Anthony Abrojena. All participants are requested to complete and submit the evaluation form, which you can access through the QR code flashed on your screens. Or you may go to Slido and use the same event code, BICVM, to access the survey form. For those online, you will be redirected to the feedback form after leaving the webinar. Boehringer Ingelheim, in partnership with the Philippine College of Endocrinology, Diabetes and Metabolism, and the Philippine Academy of Family Physicians, thanks you all for taking part in the CVM Congress, improving patient outcomes from guidelines to practice. Please enjoy the rest